control the amount of fluid in your body. And they also balance the electrolytes, the minerals and chemicals. And that can be one of the most dangerous things about when the kidneys are not working. High potassium is a very, very common cause of death in our kidney failure patients. The other thing that I think people don't quite realise so much is that kidneys are critical in terms of controlling blood pressure. They are unfortunately unhelpful to themselves in that when they sense low blood pressure, it's a physiological response to increased renin secretion, and that activates the angiotensin system, which causes vasoconstriction that increases the blood pressure. Unfortunately, that does damage the kidneys, and so I often explain to people that controlling blood pressure is one of the key components of kidney health management. Reducing the blood pressure reduces further damage to the kidney, which reduces further blood pressure increases. So it's sort of a vicious spiral kind of going downwards, and we have to hit hard early to control the blood pressure. The other thing that people often forget is that kidneys are really important in sensing anemia, and they produce erythropoietin, which tells the bone marrow to make red blood cells. So often we tell if somebody's got chronic kidney damage because they're often very anemic when they present because the kidneys are not producing erythropoietin. The kidneys are also really important for activating vitamin D. So they, as well as the liver, they act on the vitamin D synthesized in the skin, and the activated vitamin D increases calcium absorption from the diet, from the gut. But if that's not present, then the calcium is replaced by leaching the calcium from the bones and from teeth to maintain serum calcium levels, and that can cause significant weakness and lead to fractures and pain. So, why do I care about preventing kidney disease? Dialysis is absolutely hideous. It's a really, really challenging life to lead, being on dialysis forever. It's worse than chemotherapy. You've got to come to the hospital 3 times a week. You've got the additional burden of having to wait for transport if that's the way you need to come to dialysis. And it is perpetually there. It's hanging over you. It interrupts with your daily activities. The day you come for dialysis, you're often exhausted afterwards. And it's very, very difficult to retain employment when you're needing to attend dialysis and then come into hospital patients that can occur. Peritoneal dialysis is when we put a tube into the abdomen. Incredible that it was discovered. It was discovered in guinea pigs. You can't really make that up. Guinea pig, but a guinea pig discovery in guinea. And the fluid is instilled into the abdomen, and actually the lining of the peritoneal cavity acts as the kidneys. So you drain the fluid in, and then the toxins transfer across, the electrolytes balance, there's fluid drawn across, and then you drain it out. But again, you've got to do that every night, or sometimes during the day as well, if that's the preferred option. But it's there, it's haunting you, you have to do it. The symptoms of kidney disease are actually fairly non-specific, and it's very difficult to determine whether or not people have kidney disease just on the basis of symptoms. But they are the consequences of the failure to deliver in terms of getting rid of toxins, getting rid of salt and water and acid. And as I said earlier, the bones become weaker and anemia occurs. But the major problem that we have is that most people don't have symptoms until they've lost at least 70% of their kidney function. And so really, what we're trying to do is find the people below the tip of the iceberg so that we can treat and prevent before people get symptoms. And that can be very hard sometimes to really persuade people that there's a problem when they feel perfectly well. But why do we care? Well, obviously people can progress to developing kidney failure, but the majority actually don't. The majority develop other complications. We know that people that have got kidney disease, this is kidney disease stage 3, which is actually not really that bad, and I'll explain in more detail in a second, have a significant number of unplanned admissions annually because of the other health complications that can occur, predominantly cardiovascular, but also infections and frailty. If you've got more advanced kidney disease, 75 out of people end up having an unplanned admission. So that's through an emergency. So you can imagine this is very costly and very burdensome to the NHS as well as to the individuals and their families. Kidney disease is also associated with significantly reduced life expectancy, even when people have got very early disease. And you can see here that the people who have got early stage kidney disease have a reduced life expectancy over time. But those who've actually got albumin in their urine, which is a very powerful marker of kidney disease, even with a very small amount, a significantly reduction in mortality. And of the people who have got more advanced kidney disease, up to 20% of people die per year. So it really is a very, very dangerous condition. And just to highlight that in more detail, when you've got kidney failure, the survival rates are worse than having most forms of cancer. So colorectal cancer, breast cancer, you're more likely. It's only pancreas and lung, which are the two really nasty ones that kidney disease mortality rates. So why is kidney disease so bad? Well, really, it's usually, we think it's due to its impact on cardiovascular. So not only have the kidneys got enormous burden of cardiovascular disease, and they represent a big proportion of people with cardiovascular disease. This is quite an old study now from the States, and this is showing all the different types of cardiovascular disease: atrial fibrillation, peripheral vascular disease, coronary artery disease. And you can see that 50% of these people in the States had chronic kidney disease. So it really is accelerating cardiovascular disease, but also the common causes of both conditions. Just try and, yeah, brilliant. And we know that if you reduce kidney function, you're much more likely to die of cardiovascular disease than people with normal kidney function. This is showing differences in people with more reduced kidney function as it goes moving into the pink, and that you're twice as more likely to die from cardiovascular disease than people with normal kidney function in the blue bar here. But interestingly, we think that actually it's not just the way that the kidneys are cleaning the blood, the function itself, but actually it's how the endothelium, the lining of the blood vessels in the kidney, how healthy that is, which is the kind of most important predictor of developing cardiovascular disease. And that we know that when people are having the furring of their arteries leading to heart attacks, strokes, TIAs, that concurrently people are having progression of their kidney disease, and the kidneys are starting to leak albumin. And that is one of the most powerful predictors, way over other traditional risk factors, which I'll show you in a second, of having a cardiovascular event. So this is the slide that I wanted to share with you. You can see that with increasing levels of albumin in the urine, because the blood vessel layer in the kidneys is damaged and it's leaking through into the urine, we can see that even for the same level of kidney function, people with normal kidney function in the blue here, if they've got albuminuria, that they're more likely to die of a cardiovascular event than someone with very reduced kidney function, down to less than 45%. So albuminuria really is the horrible predictor. And if you've got albuminuria and you've got reduced kidney function, you're 12 times more likely than somebody without kidney disease to develop a cardiovascular event. And this is one of the kind of key learnings in my last 5 years, that actually if you're comparing people with risk factors for cardiovascular disease, you can see here that people with no diabetes and no kidney disease are in red. If you've got diabetes, you've got up to a 3-fold increase in these different cardiovascular events. If you've got no diabetes but kidney disease, the blue bars here, you're more likely to have cardiovascular disease than someone with diabetes alone. Hoping I'm explaining this clearly. I always get my words muddled. But if you've got diabetes and kidney disease, your risk is so high of having cardiovascular events. So you can see what I'm trying to show you is that kidney disease is actually even worse for developing cardiovascular events than diabetes. So it's a really important thing that we need to look out for. The good news is that actually if you reduce the albumin in the urine to protect the kidneys, you're likely to have a positive impact to reduce the number of heart attacks and strokes. So this is a really old study of people with diabetic kidney disease, but actually if you start to reduce the amount of albumin in the urine, then actually you reduce the number of cardiovascular events. So we need to find albumin in the urine to treat people to prevent them dying from cardiovascular disease. But this is one of the most fascinating things for me, and very, very tragically, and motivates me to do my research. People who get kidney disease are those marginalized communities, people from ethnic minority groups and people from lower socioeconomic groups. And it's quite difficult to unpick the relative contributions, but they are the ones that are coming to our dialysis units because they've got kidney failure. Women are more likely to be diagnosed with chronic kidney disease, but actually men are more likely to start dialysis. We haven't really unpicked an explanation for. But one of the things that really motivates me to do my work is that such a high proportion of people from ethnic minorities, but particularly Afro-Caribbean communities, are affected by kidney disease. They develop kidney disease at a much younger age, and of the patients that I look after on dialysis at the moment, I've only got one person who is white in southeast London, and that obviously we know that there are a lot of people of black ethnicities living in southeast London, but that is absolutely unacceptable that they're disproportionately affected by kidney disease. So we know that in the general population that people of African ancestry are threefold more likely to develop kidney disease. And at King's College Hospital, we look after one of the highest proportion of black people of black ethnicity with kidney failure. Sorry, my slides don't really quite show things properly there. But I've already said that they are so young. I've got so many men in their 30s and 40s, women too, but more men that are on dialysis, and it's really hard. They've got a much longer wait to have a kidney transplant, and they're really struggling to work and to support their families. This is just really showing that the increase in risk for people compared with different ethnicities in the UK. So you could see that in this analysis that you're twice as more likely to develop kidney failure. But interestingly, across the globe, we've got very little information from other areas that have got high proportions of African diaspora and Africans themselves. In the US, obviously, African Americans are very well studied, well, better studied than in other high-income countries. But you can see that we don't actually know much about the prevalence of kidney disease in Africa. But one study has actually just recently been undertaken, which shows that it's high. And as you'd expect, it's rising because of the increase in numbers of people with diabetes and heart and hypertension. And one of the things that I'm most worried about is the fact that it's going to become increasingly common, that kidney disease is going to be the fifth common cause of death over the next decade. And the exciting thing is that we've got the opportunity to prevent and protect people from kidney disease. My biggest fear is that people are working towards building dialysis units to treat people with end-stage kidney disease rather than working upstream to prevent. One of my other big concerns is that we're kind of focusing on the standard risk factors for cardiovascular disease, diabetes, smoking, obesity, high blood pressure. But actually some of the other causes, particularly in people of African ancestry for kidney disease, are not being addressed and explored. We know that people who have a lot of events of acute kidney injury, kidney damage due to concurrent infection or dehydration, greater risk of chronic kidney disease. We also know that people with who are African have got slightly higher, bigger glomeruli, to be at greater damage, the glomerulus, which is the filtration unit, and fewer numbers of nephrons, which again makes them more vulnerable. There's also pandemics in different parts of the world, and I think so in Africa that we haven't managed to identify yet due to various toxins that are being used in industrial and also the working environments that people are having to undertake, work in very dry environments and not wanting to take water so that they're not having to waste time by going to pass urine. So this is, watch this space. I think that that's going to sadly be a big cause of end-stage kidney disease in the future. I also do some, I'm very interested in preeclampsia and obstetrics, and I was preparing my slides, I just couldn't help showing this picture because it just makes me smile so much. It's just absolutely adorable. But just to highlight to you that it's very, very important to protect kidneys from the beginning of life, because the kidneys actually develop after birth. So we know that they start to develop up to sort of 36 weeks, but then it's after babies have been delivered that they still continue to increase in size and function. But if babies are delivered early, and we know that lots of African babies have got a higher rate of being delivered early, both in the UK and in Africa, that they are much more likely to develop chronic kidney disease. I won't bore you with all this. There are lots of kind of reasons for that, but the majority of it is to do with that they have reduced numbers of nephrons, which means that they've got those nephrons have got to work harder and they start to fail sooner. This is not a very clear slide, apologies, but this is a study from the States which basically looked at the birth weight of babies and whether or not they were early. And basically, if you're a lower birth weight or you're born early, you're much more likely to develop kidney disease and end-stage renal failure. But this is one of the most exciting things that I think happening at the moment in terms of changing the trajectory of kidney health in people of African ancestry. And I feel very, very appalled that it took so long to identify, but there's a genetic cause for kidney failure. And it was identified actually in African Americans. There are these different genes which code for a protective protein against sleeping sickness. So G0 is the kind of normal variant, but people who have these different genes, G1 and G2, you have one of each. You have two of these different genes. The people that have got G1 and G2 are much more likely to develop kidney disease, but much less likely, excuse me, to develop sleeping sickness, which is obviously a massive killer, particularly in this West African variant. And so a lot of these genetic changes are much more common in West Africa, and with the horrific slave trade as well, they're much more common in African Americans and people in the West Indies. And we actually know that they appear to be much more common in certain tribal groups as well. So the Yoruba tribe has a very high proportion, and also the Igbo tribe, particularly of these G1 changes. So we know that people who have got 2 copies of these high-risk variants are much more likely to develop kidney failure over time. So what we're trying to do now is identify these genetic changes so that we can find people quickly and early to protect their kidney health. It's estimated that up to 70% of people who are on dialysis in the States who don't have diabetes have got these different variants. And we've looked in HIV population UK, and again 50% have these high-risk genotypes. We're now looking in a population of people without HIV, and again the same pattern is there. So a lot of the people that we've previously thought have just got high blood pressure and it's damaged their kidneys, yes, they've got high blood pressure, but it's the genetic APOL1 disease that is damaging the kidneys. And we're now learning that this is part of a process in lots of different kidney diseases, lupus particularly, HIV, as I've said. And I'm really interested. I think that it is accelerating progression of kidney disease in people with diabetic kidney disease too. The exciting news is that thankfully the pharmaceutical companies have finally noticed this problem and they're developing treatments. And this is a treatment that we recently published in the New England Journal called inaxaplin. Reduces the amount of protein in the urine. And there are 2 other therapies that are now being developed. But the key thing for me is to be able to find people early, because a lot of the people that I try to enter into these trials have actually got very advanced kidney disease by the time that we see them, and they're no longer eligible to have these treatments to protect their kidney function. One of the things that I describe as the elephant in the room is the fact that the majority of the people that have this kidney problem are actually in Africa. And one of the key challenges in terms of developing these new therapeutics is whether or not people are going to actually be able to afford these treatments in Africa. And thankfully, a lot of the ethical regulations are now stipulating that they have to be provided beyond the trial period. We also, it's interesting, I had a very interesting conference recently with people who are experts in trypanosomiasis, so the parasites that cause sleeping sickness, and they're very concerned that by people's immunities that there'll be lots and lots of cases of this new trypanosomiasis, which the genetic variant actually protects against. So the good thing there is that a lot of people who have these high-risk variants don't go on to develop kidney disease, and we're just trying to understand what switches the genes on and how we can switch them off again. So that's another piece of work that we're doing, and Rosalind's kindly helping me. Moving on, I suspect most people know this, but we check for kidney disease using creatinine, and we dip the urine for albuminuria, which I've already told you about. And we often do kidney ultrasounds, and I'm really excited that this is being developed with AI now, so that hopefully at some point in Africa, we'll be able to do it without actually having skilled people to be able to do ultrasounds, that we'll be able to swipe over the back and the computer will somehow, by magic, determine whether or not somebody's got kidney damage or not. We use creatinine, but it's really not an ideal measure of kidney function. It's actually produced in the liver, creatine, and then it's processed by muscle and then got rid of by the kidney. The reason why we use it is because it's so cheap and it's readily available. But we know that if the kidney function reduces, that your blood levels of creatinine increase. The problem is that if you've got lots of your liver production of creatinine, or you've got a lot of muscle mass, that your creatinine level goes up, even though your kidney function is normal. And this has led to lots of complexity in terms of interpreting kidney function in people of African ancestry. There was a historic assumption that a lot of people had higher muscle mass, which in some people is definitely true, but not in the majority. And so people always thought that, oh, people have just got high creatinine and therefore they've got lots of muscle, and not recognizing that actually their kidney health wasn't good, and that the creatinine was risen because it wasn't being got rid of by the kidney. Interestingly, I'm fascinated, just recently found out that it's a genetic variant as well, that means that people produce more of the creatinine precursor in the liver, and that's only 60% of people of African ancestry have that gene, and it's not in any other populations. So again, that might be a genetic basis of why the creatinine is higher in people of African ancestry. So we use the creatinine to interpret the level of kidney disease, and we use equations to understand exactly what the kidney function is, because creatinine is imperfect. We could measure it directly, but it's quite tricky. It requires 4 hours of monitoring and taking lots of blood tests, so we don't actually do that. And these fancy equations, and I certainly don't know how to calculate them directly, I just put them into the computer and it gives me a number. But these equations have been used to help us estimate kidney function and glomerular filtration rate, which is how well the kidneys are working. Now, unfortunately, these equations were derived in very random populations. The first equation that we no longer use at all, Cockcroft-Gault, was measured in 17 white medical students. So nobody of African ancestry was actually school. Then this MDRD equation was developed, which suggested that there needed to be an adjustment if people were African American. And sadly, that was just adopted across the whole world, and everybody assumed, oh, if you're Black, then you must have this adjustment factor. And we found in the UK that actually this meant that people were being disproportionately recognised to have higher kidney function than they should have been, and actually they had kidney disease and it wasn't recognised. These equations have kind of been developed and progressed, and in 2021 there was a big push. We found that it wasn't accurate in our populations in the UK, and then in the States they abolished the use of this ethnicity correction because they felt that it was important not to use race-based medicine, which I wholly agree with, because there were different assumptions made about who was Black, who wasn't Black, how you should calculate the equation of people of mixed race. But I think that we're still not measuring kidney function well enough, and that's something that we definitely need to work on in different communities with different ethnic diversity, so that we actually can do much better for those that are most affected. So this is how we kind of measure kidney function, and we measure the glomerular filtration rate, and people kind of fall into these different categories depending on how reduced the kidney function is and then how much albumin that they've got in their urine. So you can see that we worry about people if they've got albumin in their urine, even if their kidney function is pretty good. But the problem that I've already mentioned is that lots and lots of people aren't aware that they've got chronic kidney disease. Why is that? Well, I think sadly that I know that GPs are under a lot of pressure to perform at the moment, but there is no mandate for checking urine and for kidney disease in people with these high risk conditions anymore. People are pretty good with people with diabetes and they check for albumin in the urine then, but people with high blood pressure, very few get kidney health checks, and even fewer with other risk factors like having a family history of kidney disease are not checked at all. We can predict who's going to develop kidney failure now, but we need both the kidney function and also the amount of albumin that somebody's got in their urine to calculate whether or not they get kidney failure at 2 years and at 5 years, which is very helpful. And this kidney failure risk equation is now being recommended to GPs to decide who to refer into kidney and into nephrology. And then now there are all these fancy AI models, which I think is going to really change practice. Predicting kidney failure from different particular different groups. So watch this space. One thing that we do know, though, that even if people have been diagnosed with kidney disease because they've got reduced kidney function on blood tests or they've got albumin in the urine, unless it's actually reported in their GP records that people do badly, and we know that actually unless it's coded within the GP records, people are much more likely to die because they're not having all the preventative treatments that we need. And this is the forecasting of what the number of people needing dialysis is going to look like in the UK over the next few decades. And I think very few people realise that the cost of kidney failure is astronomical. For the small number of people that receive dialysis, it costs 2% of NHS money, and each person receiving dialysis costs £30 per year. And for that, you could test over 1,000 people and you could treat 150 to protect them from kidney failure. So I really think we need to stop spending the money on dialysis and go upstream. Move on from that slide. The exciting thing is, though, that countries that have had a really active campaign to detect early kidney function and to start therapies are actually starting to see a downturn in the number of patients. This is Japan and similarly in Portugal and Germany. They're starting to see a reduction in the number of people that are starting dialysis, which is really exciting. It shows that proactive measures can help, and that the new therapies are potentially going to work. I'm not going to go into all this detail, I promise you, partly because I don't even understand it myself. But the exciting thing is that we have new treatments to protect kidney function. This is the real game changer at the moment, the SGLT2 inhibitors that are also used to treat diabetes, dapagliflozin, canagliflozin, empagliflozin. And then the GLP-1s are actually going to potentially be a big game changer. This is semaglutide, the anti-obesity drugs. And then there are newer ones that affect the aldosterone pathway as well. So these three treatments are going to be massively effective in terms of protecting against kidney disease. And this is just to demonstrate that if you're on an ACE inhibitor for your blood pressure and you have an SGLT2 inhibitor, dapagliflozin, you can prevent people developing kidney failure by up to 15 years, which is extraordinary. But what you want to do is start people when they're on this bit of the journey rather than when they're on this bit of the journey, because you only have a little bit amount of benefit. So these are the kind of recommendations, and Rosalind's going to talk a lot more about these important lifestyle changes. But we do have a lot of treatments now, which is why we want to find people sooner rather than later. And this is some health economics. I kind of don't understand it in much detail, but the forecasting from Kidney Research UK is that if we actually diagnose people early, we can reduce the cost by a huge amount if we just generally better manage people and then introduce these SGLT2s. We can actually make a massive cost saving for the NHS, which we all know needs a lot of support at the moment. Rosalind, sadly, I don't think is going to talk in great detail about this. And I just really wanted to kind of give her a shout out about the amazing work that she's been doing, training peer educators, talking to community experts, including expert patients, to really get the message out, and going into community spaces and doing early kidney health checks. And she's tested over 1,600 people and found a huge number of people with early kidney disease. She's engaged with them, she's spoken to them, she's educated them, and she's supported them to go to their GPs to start treatment. And I think that that is an extraordinary achievement. And now we hope that this is going to be adopted for scale up across the UK, targeting different high-risk groups, including people of African ancestry. So next steps are that we're trying to do more in this space. We're trying to work hard with the cardiologists. We're the Robin to their Batman, so try to kind of adopt their strategies and work with them closely rather than reproducing activities. And bringing back to the UK some of the point of care diagnostics that we've been doing in Africa, checking for kidney health, creatinine with a finger prick blood test, which I think hopefully going to be a game changer. And we're hoping one day to get some more funding to be able to do the genetic test, the APOL1 genetic test, very quickly. I know it doesn't sound very quick, but within 40 minutes rather than 40 days, which is how long it would normally take, so that we'll be able to give people their results and start treatments more early. So hopefully one day we'll be moving towards health equity and even justice in terms of preventing the disproportionate burden of kidney disease on marginalised groups. Thank you very much. Over there. Thank you. I'll pass on to Rosalind now. Oh.
Thank you so much, Dr. Kate. That is a really brilliant epidemiology and understanding to kidney health and kidney disease. I'm really shocked the amount of money that it takes per patient, per dialysis in a year. And some of these things, I think, preventative medicine is much better than treating things at the end of the spectrum. So I think it's very important raising awareness to our communities, especially with your statistics that you said usually Black, ethnic, and other minority groups, if they do develop kidney disease, they tend to develop faster and progress much faster to the end spectrum of the disease. So it's important for us today to be equipped to know actually how do we adjust our lifestyles. We cannot change the genetic component of it, and I know there's a lot of research going to understanding how genes play a role into this. But there's one thing that we can definitely do is to adjust our lifestyle so that we reduce the risk factors that can lead to kidney disease, and also things that can lead to faster progression of the kidney disease should it be picked up. So it's very important, and we're so grateful for your contribution, not only to our platform today, but globally for the work that you do, and within the UK for the actually the wonderful work that you do. So I don't know whether, Rosalind, you are ready to share your slides and to take us to the second phase of our talk today, which is actually talking more about what are the symptoms, what do we need to do, what should we look for in terms of the kidney health or kidney disease. So I think there are lots of questions on the platform and on the chat box and text messages, Rosalind. People really want to understand what are the underlying factors of kidney disease, what are the symptoms, what are the signs. So let's all tune in to get the second bit of information today from Rosalind. Rosalind, over to you.
Thank you very much. So, yes, I know that Dr. Kate has gone through the the signs and symptoms, which I have to say that, first of all, the signs and symptoms don't really show until about 70% of the kidneys have been lost. Also, if we look at some of the signs and symptoms, they are really general and non-specific. So some people may complain about tiredness. Some people may complain about weakness. It takes a longer time before these signs and symptoms show. Most of the time, people would have gone to their GPs with a completely different problem, only to be told that they have poor kidney health. So for individuals who have high blood pressure, as well as individuals who have diabetes, we know that their risk of developing poor kidney health is actually higher. So these are the two main contributors of poor kidney health. However, we also know, like Kate has just mentioned, about genetics, and especially the mutation in the gene that was initially protecting us against sleeping sickness. These are facts. We also know that pregnancy-induced hypertension also increases that. Obesity, we also know that increases the risk of high blood pressure. I also have to say that sometimes we use herbal medications. So that is not to say that herbal medications are not good. But where it becomes very complex is when we have medications prescribed by our GPs, and then we also have herbal medications bought for us from home, and we tend to combine these. We don't know the side effects of the impact that the herbal medication could have on some of the medications that our GPs have prescribed for us. So key thing is actually knowing our own risk. It also runs in families. So if a family member has it, especially the one associated with genes, if a family member has it, especially a mother or a father, there is that increased risk that other members of the family, siblings, children would also develop poor kidney health in the future. It doesn't mean that if we look after ourselves, we would end up with poor kidney health. So these are the main risk factors of developing poor kidney health. And like I said, the signs and symptoms do not really show at the beginning until we have lost about 70% of the whole kidney function before signs and symptoms such as tiredness, inability to concentrate, weakness start to show. And for some people, if they already have high blood pressure, they would notice that their blood pressure starts becoming very difficult to manage. And then also those with diabetes, they would notice that sometimes the diabetes medication that they've been given is not working, because the kidneys also in a way helps to actually conserve insulin or makes insulin more sensitive. So if the kidney health is going down, then the amount of insulin people are taking, or if they are type 2 diabetes, even the amount of insulin that they all have doesn't work as effectively as they would want it to work. So these are the main risk factors, as well as some of the signs and symptoms. What I want us to focus on, sorry, when Kate was talking, Kate mentioned about how the kidneys help to protect bone health. So for some individuals, when the kidney health start going down, one of the things they also start complaining about is bone pain. Because when the kidneys are not functioning very well, it is unable to help the body in activating vitamin D. So what the body does is to go and remove vitamin D from two main sources, which is the bones as well as the teeth. So sometimes some people would lose their teeth, but the bones become brittle, which makes people developing poor kidney health at risk of actually falling as well as having fractures or breaking their bones. What I want us to focus on is to actually look at how can I promote my kidney health. We don't want people to develop poor kidney health. We want people to promote their kidney health before we get there. Kate and I, our passion is to go upstream and actually find people earlier. So how can I promote my kidney health? And I start with, it all starts in my mind. Because change, behavioral change, is not easy. So what we are going to talk about will require us to change, and behavioral change is not easy. It takes discipline, it takes accountability. So what am I telling myself? How is my whole mind connecting to my body? Because the way my mind and my body works affects my overall health-being. And for those of us who are Christians, we know about this tripartite. We know the body, soul, and spirit, and we know that together, that is what helps us shape our mind, but also pivotally impact on our overall health. So let's start with the first one. It is so simple. Kate mentioned dehydration from certain areas where, although the temperatures are very hot, people also do not want to drink water because they feel it might interfere with their work or they need to go to toilet very often. But all the kidneys need or the body needs is water. 60% of our body weight is actually water. So the next time we go to do a wee, let's look at the color of our urine. Is my urine actually having a smiley face, or is my urine so sad? As in, is it number 6, number 7, or number 8? The darker my urine is, the more it is telling me that I am not drinking water. Unless I am taking other medications that make the urine color that way, but my urine color says it all. And although this part is only talking about the color, also, how does my urine look like? Does it look foamy? Because my urine should not look foamy. Does my urine look foamy? If my urine looks foamy, there is something wrong with my urine and there is something wrong with my kidneys and I need to book an urgent appointment with my GP to find out why my urine is foamy. So that's the first one. The first one is basic enough. Am I drinking enough water? Food. And for us, we love food. But how much is on my plate? If we look at this plate here, we can clearly see the portion of my plate that needs to be starchy food, the portion of my plate that needs to be vegetables or fruits and vegetables, and the portion that needs to be protein. I am a Ghanaian, if I take a typical Ghanaian bowl, what you are going to see is a big fufu. Or sometimes you have a medium-sized fufu or banku, but you have a lot of fish and very little shito, very little veg to go with it. What is currently driving high blood pressure and diabetes in Africa is actually stemmed from our lifestyle, and it is about our food. Okay. Also, essentially, what time are we having dinner? So yes, at the moment, we are working very hard and we come back home very late. And that is the time we are going to have dinner. Like somebody said to me this afternoon, that is the time we are going to have dinner. But key thing is, although I may be having dinner late because I am still hungry, the key thing is what is on my plate. Because I can still play with this plate late in the evening to have more vegetables and less starchy food because I'm eating very late. But in the course of the day, if it's the morning or afternoon, I can flip this plate around and have more starchy food because I know I'm going to work. Unless my work is a sitting down work where I am not going to use a lot of energy, then I need to know how I'm going to play with this plate so that I do not store so much starch. And we'll come back to starch because there are other fancy information I have found about starch, and I'm hoping that it will thrill all of us. So here, I have a bowl of kenkey. Now, for me, I was shocked to find out that just one small bowl of this kenkey is 331 calories. Then one of the things I quickly went to do, how many minutes do I have to walk to actually burn this kenkey? And then I was surprised. For me to even lose just 100 calories, I have to swim for 14 minutes, jog for 10 minutes, and walk briskly for 20 minutes. I'm like, wow. I look at chin chin, or what we call chips. 100, so just a handful, 100-gram scoop of that is 360 to 510 calories. If we look at this food there right in our palms, some of us may say that this amount is actually too small for us. However, if we look at the calories that it contains, it's a lot of starchy food. Question is, at the time of the day that we are eating this, and possibly may not be this portion, possibly twice of this portion, what are we doing? Because if we are not going to utilize this energy, then we do not need to eat so much. We have to bear in mind, the more starchy food we eat, the more energy, but the body is going to take what it needs because every body tissue needs energy. The body is going to take what it needs, but the rest is going to be stored as fat. I love my Gary, and although I don't make it into a bar, but I was surprised to find out that just 100 grams of Gary is 360 calories. I was like, okay. A tool that I found was about this tool here. So if you scan this QR code, it has an app. What I find this app does is that all you have to do is to scan the food that you are going to eat with it, provided you bought it and there is a there is a barcode on it. It scans it and then it tells you how much calories is actually in that food. Okay. Okay, so let's think about healthy swaps. This would be a typical African plate. You see the amount of chicken on that plate and the rice. And if we look at how much calories is in that and the effect that has on our blood sugar alone, but look at if we swap into a small portion of the rice and then add some vegetables, how that calories decrease. The same goes with the stewed chicken and rice. So the emphasis is on we have to make sure that our plate is healthy. Well, not just the rice, but healthy as in the rice, the veg, as well as the appropriate size of protein. One of the things we have to be mindful of is that whilst we all were working and coming home late, and sometimes processed food is the easiest options for us, these are not healthy for us. These are not healthy for us, especially when we come to the ultra-processed foods. And this morning, we're just talking about how now everywhere you go, you have fizzy drinks. What does the kidney need? Water. And sometimes I get asked, Roslyn, how about Coke? Water. How about Fanta? Water. How about coffee? A little bit, but water. Because coffee in itself also acts as a water tablet. So if I drink coffee, I'm going to become more thirsty and I'll need more water. But sometimes what happens is that people drink coffee, they feel more thirsty, they drink more coffee. We need to be mindful of these. Salt. And I can tell you, salt is not our friend. Salt is our enemy. Whilst we like our food tasty, whilst we like our food flavored, salt is one of the main contributors of high blood pressure in African Afro-Caribbeans. Every single food grown already has the natural salt content in it already. So if we add additional salt to it, what we are saying is that the maker didn't know the amount of salt it needed, and therefore we are adjusting it for him. What's the question that I get? Oh, Roslyn, if we don't add any salt, the food is too bland. We have trained our tongues that way, and the cells in our mouth are renewed every 6 to 7 weeks. And if we start reducing the salt content in our diet and we are able to maintain that for 6 to 7 weeks, our tongues will get adjusted to it. We need to do that for ourselves. And I say gradual decrease in salt intake. Sometimes people say that, oh, they cannot. What I did was that I have found these low salt cubes in some of the supermarkets. So Asda has one, Sainsbury's also has one. Well, a friend of mine told me, Rosalind, they don't taste as the previous stock simply because they have low salt content. But we need to get to the bottom of reducing our salt intake to protect our heart and to protect our kidneys. If I remember, my grandmother didn't know stocks and did not cook with that, but we still enjoy the food. My mom never used stock. We still enjoy the food. How come today we cannot cook without it? And we don't only use one. Sometimes we add 2 or 3. Before we add salt to our diet, that is a lot of salt. And the impact it has on the heart is really significant. Question that I get asked, so you are saying I shouldn't use salt. How can I actually spice up my food with no salt? We are blessed with a lot of herbs. We are blessed with a lot of herbs that really do help us. Bay leaf, green pepper, we are blessed with a lot of herbs. And these all add up to the spice, to spice up our food. One of the key things most of the time I recommend during follow-up, people ask me, Roslyn, what do I do? Don't fry the food, grill it. roasted. It savors the flavor inside. Once you steam the food or you steam the chicken, all the nutrients and everything comes in the stock, which we hardly use. So it's about practical tips on what we can do to actually make our food still taste nice and protect our kidney health. And I like mindfulness. So these are a few tips I learned about eating. Please, let's spend time. Enjoy the colors in the food. You see, it's a signal we are sending to the brain. Enjoy the colors of the food. And when we put the food in our mouth, take your time and savor the texture of the food. It's a trick on the brain. The longer we take in chewing our food, the easier it is for the brain to think that the stomach is full. So eat slowly, chew thoroughly. Okay? And tip number 3, please put the mobile phones away. Switch the TV off, switch the computer off. And why do we say that? The brain is very sensitive to stimuli, but our brain cannot process a lot of stimuli. So if I am watching the TV, my eyes are watching the TV, my ears are listening as well. My brain cannot then concentrate on food that is entering my stomach. So even when I am full, my brain cannot tell me that. Hence the importance of putting these things away. Possibly many of us have done it. So you are sitting in front of your computer and then you have a packet of crepes or a sweet that you are eating. So you are busy eating and then while you're working, then after a while you start looking for the packet of crepes and then you're wondering who took it. But nobody has taken it. We have eaten it, but our brain has not been able to tell us that our stomach is full because it is busy focusing on what we are doing. So let's listen to our body cues. If we feel full, let's stop eating. And please, change is about making mistakes and we learn through mistakes. So when we make a mistake, the day we add a lot of salt to the food and we feel we cannot taste that, let's be compassionate to ourselves, but focus on making positive changes. Because we cannot say, okay, I've made a mistake today. Okay, tomorrow too is a mistake. The following day, then it then becomes a habit. Oh, sorry, I've gone through this one already. Keep on moving. Every step counts. Exercise is really, really great. Exercise is pivotal, but it doesn't have to be boring. So 2 of the easiest one that I recommend is the first QR code is Encanto Dance. Believe you me, you will enjoy it with the kids. It was made with kids in mind. It's made to be enjoyed as a whole family. Try it. And then there is the family fun cardio as well. And exercise doesn't have to be boring. In fact, you can actually do your dishes while you're dancing. I do the dishes while I'm dancing. I do the ironing while I'm doing stepping. And some of us do not have that time to say, I'm going to the gym. So what can I incorporate in my daily life to keep me still active? Can I come up from one bus stop earlier and then walk? Can I plan to do that? I have to be intentional. Change is about being intentional. I have to be intentional and I need to set myself goals on how I am going to achieve this. If I leave it to chance, nothing will change. Nothing will change. Sorry about that. But how about if I have diabetes? How can I protect my kidney health if I already have diabetes? Simple. Know your diabetes ABC. First one is A1C, which is the blood sugar over 3 months. Let's try and keep ourselves in the green area and not in the amber area. And even if we find ourselves in the amber area, let's make conscious, intentional steps to bring ourselves back in the green area. The next one is blood pressure. Let's keep the numbers down. Okay. And the 4th one is cholesterol. And this is about what am I eating that I think contains high fat content, but then also looking at the ultra processed foods. And if my GP has prescribed a particular statin for me, is it working? And if I have side effects from those statins, can I report to my GP? Okay. This is what I would say about medicine. A lot of the medicines that are available have not been trialed on Black people simply because Most Black people are not involved or recruited into researches. There are processes towards that. So the dose that a GP may have started with us may not work for us, or that particular tablet may not work for us. But if we do not communicate with our GPs that it is not working for us, or this is the side effect that I am having, the GP would not know and would not change it. A particular medication does not agree with you, please, let's speak with our GPs instead of stopping taking them. Okay. What if I have high blood pressure? Is the same. I have to know my blood pressure ABCs. So first is albumin, and Kate has spoken about this big protein, which shows in our urine very, very early on when the kidney starts struggling. And they are so important. They can actually let us know the early onset of poor kidney health. And all we have to do is to look at lifestyle changes to help the individual or to help each other to reduce the protein or the albumin leak from our kidneys and then protect our kidneys. And if that doesn't work, then our GPs may add one more tablet to help protect the kidneys from the albumin leaking, which stops the albumin leaking completely. The next one is the blood pressure reading itself. Am I keeping it down? Okay. Again, we have seen cholesterol here. And then another thing about knowing my blood pressure ABCD, sorry, is diabetes. Am I at risk of diabetes? And can I check whether it is not just high blood pressure I have, but there is an underlying diabetes as well? So now I have done the urine, and now the final thing I add the E, which is I add the EGFR, which Kate mentioned. That is a complex test, but that is the easiest one for us to assess kidney health. One thing that fascinates myself as well as Kate is that we love making kidney health a priority for our community because we know that we are disproportionately affected. So we love, nothing gives us joy than going into the community and then engaging with people. We want to take the NHS into the community. We don't want to sit and wait for people to come to us. We want to go to the community, take the NHS there. So what have we done? We have trained community members as kidney champions, and we go into the community to screen people. But please, let's start talking if we have any underlying concerns or worries. Let's share our concerns and worries with our friends and families, our faith leaders as well, because they will be able to signpost us to resources. So I would like to end with, again, my mindset. What we've spoken about today is about making slow, steady changes, but it is all going to start in my mind. And if I tell my mind I can do this, believe you me, I can do it. However, if I tell my mind I cannot do it, this is too much, this salt, I cannot stop eating this salt, then I am not going to make even any intentional effort. But you know what? I would end those of us who are here, who go to church. God has not given us a spirit of fear. So we know that He's given us the will and we can do it. So let's take responsibility for our health. We have to be intentional about our health. Nothing will change if we don't do anything. So today, will we set personal goals for our own personal health? Are we going to find a health buddy and hold each other accountable? That's the only way. And those of us who have high blood pressure or diabetes, do we know our kidney health? Do we know whether our GPs have checked our kidney health in the past 1 year? If not, we can ask our GPs again. And those of us who do not have anything, have we checked? Do we have our annual health check done? Are we due? Did we do that last year? And if we didn't do that, please, I will encourage all of us. Annual health check is free. I will encourage all of us to engage with that. And my QR code has gone missing, but I have a QR code. I will include it when I'm sending the slides again, where you can get a free kidney health risk assessment. So the QR code, what it does is to give a risk assessment, and then you get tips on what you can do to promote your kidney health. Thank you.
Thank you so much, Rosalind. That was really, really great insight, especially the slide I liked most about fufu and and the calories that contain in our fufu, because I can tell you my fufu is not that size, even maybe a bit bigger. So it's actually a 360 degrees check
Yeah.
that we all need to do on what we take and how much we take, what we eat, but also at what time do we eat heavy meals that are not digested. Yeah. I also liked about the family exercise as well, and it's very dear to us as CheapNet. We do have our partner organization, Healthy People, and our aim is to keep fit and evangelize. So every Saturday out there, 10,000 steps, keep fit, run, do exercises on the Zoom every morning. You need a healthy body in order to do what we can do. So thank you so much, Rosalind. That's really, really grateful. So we will have a question and answer session. So there are quite a few questions that have been posted on the platform, both for you, Katie, and Rosalind as well. And we will just answer them as I will ask you as we go along, and people can still post as many questions as they need on the platform. But also, if you want to raise your hand to actually ask the question yourself, please feel free to raise your hands. We'll pick up.
Sorry, Kim, you've gone mute.
You are
So,
muted.
yeah, can you hear me?
Yes,
so the
we
first
can.
question, I think maybe Katie or Roswin, both of you can answer that. It says, what are the basic symptoms of kidney disease? I know you touched about it. To say, sad to say, in majority of the cases, it's asymptomatic until towards the end of the disease that you get to see a lot of symptoms. So maybe, Rosalind, if you just want to maybe shed some lights or summarize a little bit so people can understand.
One of the most amazing things that Kate mentioned was about the 16 kilometers of the nephron. Now, whilst that is good, what it also means is that because it is such a vast surface area, it just adapts and adapts until majority of it is completely destroyed. And hence, the early part where people would, let's say somebody with sepsis would feel so unwell at the beginning. With poor kidney health, it doesn't show any symptoms at all. If we think about the fact that the kidneys help in making red blood cells, so we are thinking that the person would have anemia, but then anemia shows later. So they may feel weak, they may feel tired, they may not be able to concentrate, which may be a symptom of anemia. In terms of the kidneys helping to activate vitamin D for bone health, they may have bone pain. Also for the electrolyte, they may have a muscle pain or muscle cramps, which may be because there is imbalance of sodium and then other electrolyte. It is only towards the latter stages where people may feel that their body smell of urine. It is also not very common, but some people may experience a metallic taste in their mouth. Some people may also find it difficult to sleep, especially for the men. Because of anemia, they may develop impotence because there is no blood flow to the penis. The women may also develop poor libido because there is no blood, so that desire is not there. So some people may also struggle with concentration. But like we said, these do not show at the beginning. It shows at the later stages. Easier to pick are those who have underlying diabetes or hypertension, because sometimes they may realize that their blood pressure is difficult to manage, but it is simply because there is that poor kidney health, which is then impacting on the heart, which is then again impacting on the kidneys. So it becomes this vicious cycle of the hypertension, the high blood pressure affecting the kidneys, and then the poor kidney health in turn affecting heart health, which then impact on the kidney health again. So I think these are the brief summaries that I would say. In terms of mental well-being on poor kidney health, I would have to say that it also doesn't show early. It shows at the latter stages. It is actually worse in those who start dialysis than those who are not dialyzing. But the early stages, hidden, very silent, very subtle.
Thank you so much. And I think that's where the broad topic of chronic kidney disease, hidden community disease, it's enlightening to know that. So the onus is on ourselves to look after our health. And someone has asked, how frequently should we go to our GP or NHS services or private doctors or wherever we can find help to check our kidneys? Is there a standard timeline? Is it incorporated as a national screening service for everybody to access, or actually you should just go to your GP to say, look, I'm concerned, I just want to be checked that I don't have any underlying kidney disease? How do we go about it? What should we do?
Could I answer that one, Rosalind?
Yeah, please go for it.
Yeah. So if you've got diabetes, it's mandated as part of your diabetes checks to have your kidney health checked every year, which the GPs are actually pretty good at doing. In terms of people with other risk factors for kidney disease, so having high blood pressure or having a family member with kidney disease, there's no recommendation in terms of how frequently you should be tested. But it looks like from the literature that probably every 2 to 5 years, I know that's a bit vague, but every 2 years if you've got high blood pressure, possibly every 5 years if you've got a different risk factor. So that still, if you haven't got kidney disease, that's great, but important to kind of keep checking. But it's not going to come on just really quickly and you're going to miss it if you've got high blood pressure, for example. But it's important to kind of have those regular checks. And in terms of actually actioning and getting a check, the GP should be following the NICE guidelines. And if you've got a risk factor, they shouldn't be able to turn you down if you're wanting to have a kidney health check. I know that sometimes it can be very difficult, but the kind of key message is to say, I've got high blood pressure, I want my kidneys checked, or I've got a family member that's had kidney problems. It wouldn't be unreasonable either if you're just generally concerned about kidney health problems, because particularly if you're from an ethnic minority group, it would be not unreasonable just to request a kidney health check, even if you haven't got any other risk factors.
Oh, thank you so much. And that's why I think that the program that has been running on, instead of waiting for communities to go and seek help at health services or health centers or GPs or hospitals, it's rather for the service providers and charitable organizations to go to actually in the communities and offer screening to the communities, and maybe targeted screening among faith communities, among Black ethnic minority communities, so that at least we can raise awareness. Because when you come, especially maybe centers like London Central or Manchester Central, you find out that if you go to the dialysis ward, majority of the people there are from ethnic backgrounds. So if we can do something as healthcare professionals and support our communities in the communities and raise awareness, that would be absolutely fantastic. So thank you, Kate and Rosalind, for the work that you do in partnering with CHIPNET to achieve that goal within the faith communities and African communities. The other question that someone has asked to say, if you have maybe you've been diagnosed with kidney disease, what can you do to avoid maybe rapid progression or worsening of the condition?
Do you want to take that one, Rosalind?
That's fine. So the first thing I would want to say is you've already been diagnosed with kidney disease. First is looking at what was my underlying risk factor. So was it diabetes? If it is diabetes, I need to go back to my diabetes ABC. So what was my A1C? Am I keeping in line? Am I in the green belt? And if I am not within that zone, what are some of the changes that I can make, particularly then looking at my diet again? What are the changes that I can make to make sure that my A1C is actually within the green? Because the more pressure that I put on my kidneys from my diabetes management, the more it is going to cause my kidney function to deteriorate. So what steps am I going to take to make sure that A, my diet is as good as can be? If I need to have healthy swaps, what goals am I going to set for myself to ensure that I can meet these goals? If I need any support, who else do I need the support for? Secondly, it is about looking at my blood pressure. Do I have any blood pressure tablet prescribed? Are they working for me? If they are not working for me, I can go back to my GP and I say, these blood pressure tablets are not working for me. I have spoken with a lot of people who would say that they take a particular tablet, it makes their feet swell, and because of that, they stop taking it. And the recommendation I make is that every blood pressure tablet is different, might work for you or not work for you. But if you are having side effects, as in you've just noticed that your feet is swelling, please go back to your GP and then tell your GP this is what you have noticed. And the GP would be more than happy to actually swap it with another one. However, if you do not say anything to the GP will assume that it is working. And the next time you go, if the blood pressure is still high, the GP is going to add another tablet, which will then stress you out and actually make your blood pressure higher. So it's important that we communicate. Also, if it is other life related, am I having a good sleep? Sleep is important. If I am not having a good sleep, it will impact on my blood pressure if the underlying risk is blood pressure. So this lifestyle changes is pivotal. How much activity do I engage in? What other practical steps could I take at home to actually incorporate physical activity? I mean, obviously, COVID introduced a lot of people working from home. And sometimes people have asked me, Rosin, I work from home. What tips can I do to incorporate exercise? The first thing I said to a friend, ditch your computer stand. And she said, what do you mean? I said, ditch your computer stand and go and get an ergonomic one that can move up and down. Get rid of your desk, your chair, and then get a stepper. In between, get out of your chair, go on your stepper, step for a while, and then come back and say, incorporate something in there. If it means standing up for a while, move your chair away, stand for a while, and then sit. Because yes, it can be tricky, but small, subtle, practical tips at home would actually help us incorporate activities right in the comfort of our home. If it is weightlifting, you don't have the money to buy weight, start with 500 ml ice water bottles. Increase the weight to the 1 liter bottles. These are practical tips. You don't need any equipment to actually train and then strengthen your muscles. So these are practical tips that people can utilize to actually incorporate physical activity and lifestyle changes.
Wow. Thank you, Roslyn. Actually, because I love rice too much, so I can start with 20 kg bag of rice, yeah?
Okay, so actually, thank you for saying rice. This is interesting. Another question people have asked me,
Yes.
Rosin, I like rice. So what do I do with the rice? The first question I ask, what type of rice? And then they will tell me white rice. And the question I ask, what about brown rice? Rosin is not nice. Okay, how about if you mix white rice and brown rice? And then they say it is tricky. And I said, here is my trick. Get a rice bowl. Mix the brown and the white already. So when you pick your rice bowl, it's already mixed. If you tell your brain that when I pick the rice, I'm going to pick the brown, our brains will not work that way because our brain naturally doesn't like the brown rice. So you will pick the white rice and all, but if you mix it in the bowl, that's it. So in the house, if you pick my rice bowl, that is it. You don't like it, well, that's the only thing I have.
Well done. Oh, fantastic, fantastic. So I'm just going to open the floor a bit to participants. So if anyone has a question they want to ask directly, please raise your hand. You can unmute yourself, or the media can help us to unmute you so that you can ask your questions directly. We utilize the sessions we have. We have expertise in the room. It's free consultation. This is information is free of charge. So let's utilize Katie, let's utilize Rosaline to help us so that we can all look after our kidneys. So let's see if there's a hand up. So let's have a look. So please feel free to ask any question to Katie or to Rosaline. Just unmute yourself or raise your hand up, or post it in the chat box. So while we are waiting for that, I just wanted to ask another question, Rosaline, in terms of pregnant women. So I'm gonna come to women in pregnancy and hypertensive diseases in pregnancy. Is there a risk factor if you're diagnosed with hypertensive diseases in pregnancy? Do you have a long-term risk of developing actually maybe kidney disease at one point, or developing hypertension at the later stage of your life outside the pregnancy?
Yes, definitely. That's an easy answer, I'm afraid. Pregnancy is a real stress test, and it reveals future health conditions. So hypertension, diabetes as well. So women that develop gestational diabetes got a 1 in 2 chance of developing diabetes later on. But the beautiful thing about pregnancy is that you have this sort of flash forward to the future, and you know what's coming. But it might be a golden opportunity immediately afterwards to take action, to change things, and to really control blood pressure so that it doesn't become a problem in the future. So yes, it's a very strong predictor of blood pressure, heart disease, kidney disease, diabetes, but potentially you can make it go away, I think.
Thank you so much for that. Yeah. So there's a hand up. Let me just see who has that hand up. Sammy, do you want to ask your question?
Yes, can you hear me?
Yes, we can.
Right, good. So yes, thank you both of you for such an insightful presentation. So on the treatment of kidney disease, Kate made mention of drugs, and I was wondering whether in the literature there has been some studies that talks about maybe the role of dietary modification in the treatment of kidney disease.
That's such a good question. Sadly, people haven't really studied it enough, in my opinion. I think there's massive potential for dietary modification, but salt reduction has been demonstrated to have benefit on reducing protein leak from the kidneys. So that definitely makes sense. But I think that there is a role for different diets with high, so the sort of Mediterranean sort of DASH diet as it's called, but diets with high content of leafy greens and high nitrate increases the blood flow in the kidneys. So that definitely, I think, is going to be an important thing to do to kind of improve kidney health. There's been a study that actually looked at different diets in African Americans in relation to the genetic condition that I was talking about. And definitely those people that are at higher risk of kidney disease because of their genetics were more likely to benefit from having a healthy diet, if you like. So I think there's a lot that can be done. I think that once the kidney disease is properly kind of kicked in and is starting to advance, that it would be unlikely to be able to kind of halt the progression without drugs as well. But certainly I think the effect of the drugs is likely to be increased by having a really good diet as well. And I often say to people, there's no point taking these medications if you're taking a lot of salt, because they're just not going to work. So that can be hopefully quite helpful as well. It's the two together, I think, that is going to be most effective.
Very good.
And
Thank you.
And Sammy, I also say that healthy diet actually starts right at the beginning. So if I am looking at actually promoting kidney health and not developing kidney disease, it starts with healthy diet. So diet plays a significant role. Interesting, somebody has asked, please, how does high cholesterol lead to kidney disease? And it all has to do with diet. So whilst the high cholesterol itself does not lead to kidney disease, it may lead to atherosclerosis. Is the atherosclerosis effect on the heart and then later on the kidneys? So it's not a direct causal link, but then it is an indirect causal link. So hence we talk about being mindful of the ultra processed foods, because we know that they are high in fat content. Something I learned that really blew my mind away, that for a lot of our fast food chains, when they use the oil for the foods that they fry, up to a certain number of times they use the oil, they need to discard it. However, they have found a tablet that they put in the oil that changes the color back to the original one. So instead of discarding the oil, now they don't discard it. And these are things that we are consuming. Now, that tablet, we don't know what else is in that tablet. So we really need to be mindful of these ultra-processed foods that we are eating. It all starts with a diet and ends with a diet.
The other thing just to add is that lots of people now with kidney disease, the recommendation is that they take a statin, which reduces cholesterol.
Yeah.
But the purpose of taking the statin in this context is actually because the statins are really beneficial for kind of calming and keeping the blood vessel healthy. So it prevents, even if you've got normal cholesterol, it protects the blood vessels, and because the kidney is so full of blood vessels, that it protects the kidneys as well. So there's evidence that if you're taking a statin to protect the kidneys are less likely to get worse, and you're less likely to get a heart attack or a stroke as well. So that's why people are kind of told to take advised, I should say, rather than told to take a statin if they've got kidney problems.
Okay. Can I ask one more question?
Please.
Yeah.
Yes, please.
Yes. So on the healthy diet, Kate made mention of Mediterranean food. And in terms of maybe like the micronutrient compositions, like what exactly are they in terms of like those micronutrient compositions? The Mediterranean food, you know.
I don't know, to be perfectly honest, what the specific ones are that are supposed to benefit the kidneys, but just to kind of have a guess, I guess the antioxidants would be very important for kind of helping the blood vessel health. The thing that I'm interested in is dietary nitrates. It's the nitrate in the leafy greens and things like beetroot that basically is converted very cleverly by your body into a substance called nitric oxide, which opens up the blood vessels. It's really important for kind of helping to lower the blood pressure. So I think that that's kind of one of the mechanisms, but I'm sure that there are millions more kind of clever micronutrients that are really important as part of that, the kind of therapy that we don't even yet understand.
Okay.
It's a very good question, an important piece of research to be done.
Yeah, definitely. And then the other thing about a Mediterranean diet is actually what we call the phyto or the flavonoids. So the flavonoids, what we've known is that one, they have antioxidant as well as anti-inflammatory. So anti-inflammatory means that even as we age, we may our risk of having inflammatory episode may increase. But with the Mediterranean diet, it actually helps the cells not to go through those changes. And then also the antioxidant also protect us as well. So these are the other things that we know about the Mediterranean diet. Okay.
There's another question as well. I don't know what this. I think it's a comment. Diet plays a pivotal role on our health. There are ongoing research investigating the dietary habits of Black Africans.
Yeah, you are what you eat.
You eat. Yeah, I think that's from Malcolm.
Yeah.
Yeah. So I cannot see another hand in the chat box. If anyone else has got any question at
Yeah,
all.
yeah, I do have one more.
Oh yeah, please go
Yeah,
ahead.
yeah. So between men and women, who are at risk of developing this kidney disease?
This is
Yeah, thank you.
Good question. Women, there are more women who've got a kidney disease diagnosis. Now, whether or not that's because they're more likely to go to their GPs and be tested, we don't know. It's interesting, though, that there are more men who end up with kidney failure. And again, whether or not men are not able to kind of look after themselves and end up presenting a lot later, I don't know. Or whether or not women decide they don't want to go on dialysis. So lots of, you've given the choice, and some people prefer not to go through that pathway, but men prefer to kind of continue with trying to have ongoing treatment, even if it's really hard. So it's a really good question. I don't really have the answer for you there.
Yeah.
Either women do have more kidney disease, and I think in certain settings when pregnancy care is more limited and people get a lot of damage to their kidneys through pregnancy, I think there's a lot more chronic kidney disease in women. But on the whole, I think there's more kidney disease actually in men, and they tend to present later.
Yeah. It will be interesting, Kate, for us to just run an audit on our late presenters or crash landers and actually tease out some of these statistics. It will be interesting for us to do that piece of work. But like that is what we see in the dialysis unit, although what the literature says is more women, but in the dialysis unit, you're going to see more men. And majority of our males tend to be the ones who crash land. They come in when their kidneys have completely failed. So that is a piece of work for myself and Kate to see what we can do with that one.
All right. Yeah, and also on that, is there a role of the sex hormones as well in that? Let's say like women in the postmenopausal stage, like how are they kind of predisposed to development compared to those in the premenopausal stage? Maybe if you want to include that as well.
Oh, such a good question. That we've just had a quick look at national data, and it looks like that women are more likely to have accelerated decline in their kidney function after the menopause, which kind of makes sense because the sex hormones protect your cardiovascular health and the kidneys, cardiovascular organs. So yeah, interesting, and it'll be interesting to see whether HRT, hormone replacement therapy, is helpful. And we've just done some work actually looking at prescribing of HRT, and sadly HRT is less prescribed in minority groups. They're less likely to be offered and less likely to ask. So that might be an important therapeutic option that isn't necessarily available yet. Good question. Loving these questions.
Yeah, I'm very passionate about menopause, and it's one of the things that we raise awareness among Black and ethnic Asian communities, because culturally we don't want to talk about menopause, and also in the society, even among the Caucasian communities, menopause was not something that people freely talked about. And I think it's recently that things are turning around the corner. There's more voice, more advocate, and about women in menopause. And actually, it's not a taboo. It's just another beautiful phase in a woman's life. So I think the more we raise awareness, and yes, definitely HRT has a role, and definitely not many women from ethnic minority group are bold enough to go and present themselves to their GP with the symptoms that they are experiencing. And sometimes they are also maybe not aware even to take the alternatives, not necessarily HRT, but things that can protect their bones because of the menopause. So yeah, it's something that we'll talk about in another CHIPNet Health Corner. And maybe Kate, when you guys have had the bit of research and some few things about HRT and kidney disease or kidney health, we could all jointly do something about that. Yeah. Thank you. I don't know whether there's anybody else with a question. I'm just going to give our presenters, each of them, maybe 3 minutes to just say a quick summary of takeaway home message to our participants, to our listeners, to our viewers on the platform, both on YouTube, here on Zoom platform as well. So I will start with Dr. Katie, just maybe a snapshot, 2 to 3 minutes. What are the key takeaway message that the audience need to know?
I think that the most important thing is that now we can protect and prevent kidney disease, and the key to doing that is to be able to diagnose kidney disease early. So we need to support people not to be frightened, and to take opportunities to actually get themselves checked so that they don't have to suffer and they don't have to experience the really hard, horrible symptoms of kidney failure, and how life transforming and difficult that is. So lots and lots of opportunities and new therapies now available, as well as lifestyle modifications that people can do if they know. Yeah, so get yourself checked and support other people to do so.
Thank you so much. So key message, get it checked out. Yeah. So maybe we can all write in our social media, hashtag check it out, kidney health. Yeah. Okay. So Rosalind, what about you? What's your 2 to 3 minute message to the participants and our audience?
First, hold the salt. Go fresh. That's the first thing I would say. Hold the salt, go fresh. Salt is not our friend. Salt is our enemy. The emphasis is on the taste, not the salt. So I want my food to taste nice, but it doesn't mean I have to add salt. So first is hold the salt, go fresh, emphasize on taste, not salt. And finally, exercise can be done anywhere. You don't need an equipment. All it takes is practical tips at home, and everybody can be involved. And let's make exercise fun, whether it is dancing, jogging, wall Pilates, chair yoga. Let's get it running and let's keep ourselves active and promote our kidney health, not just for ourselves, for our family and our communities.
Oh, wow. Wow. I like that. Salt is not our friend.
No.
Yeah. Those little cubes, mark cubes, this cube, different spices, salt is not our friend.
No.
And also exercise. So thank you so much. So I just want to take this opportunity to thank Dr. Katie. Thank you so much for sparing your time on a Saturday to come and talk to us for over 2 hours about kidney health. It's been really enlightening. And Rosalind, many thanks as well. We cannot begin to thank you so much. Your passion, your screening programs with CHIPNET about community kidney disease awareness, it's really, really impacting our communities. It's benefited many church communities, many faith organizations, and we appreciate the partnership that we have. To our participants, to our viewers, to our members who have joined us today. I think it's a warning sign that time is up. So anyway, to our viewers, to our members, to our participants, we are really grateful for all of you to come to join us today. Our numbers were hitting up to 85, 87 at one point, and we are so grateful. Please watch out for CHIPNET Health Corner. It's every second Saturday of the month, and it's 7 o'clock to 9 p.m. Next month, we have a very important guest as well. Come and join us. We have Prof. Rutimi, who is going to talk about key important things in terms of maintaining patient safety, errors that we do, how do we minimize that? So next talk will be more about governance processes and patient safety and how we can minimize errors in clinical practice and also in our day-to-day work. So Katie, many thanks. Rosemary, many thanks. And I'm just going to ask Precious, my co-host, if she could close with a closing prayer today.
Thank you very much. Thank you to Kate and Rosalind. Thank you so much for giving us your precious time tonight. We are really grateful, and everyone. Can we please share a word of prayer? Father Lord, we want to thank you for a time spent today. We just want to appreciate you. We want to thank you for the lives of the facilitators and everyone that joined tonight. We thank you for the in-depth knowledge and the wisdom that, Lord, they were able to deliver this presentation. We also pray that, Lord our God, you help us and guide us so that whatever we have taken in today or this evening, we'll be able to put it into practice. Help us so that we will live according to how, Lord God, you have ordained for us to live on this earth. Give us wisdom and knowledge so that our day-to-day journey will apply wisdom to our daily lives. We thank you, we bless you in Jesus' name. Amen.
Amen. Thank you so much. I just also want to say special thanks to our media team, Ezekiel and Abednego, for helping us tonight. So thank you, everyone. Bye-bye.
Bye. Bye.
Bye-bye. Thank you so much. Bye-bye.
Bye.
Bye, everyone.
Thank you. Bye-bye.
Bye.
Bye-bye.